not so good. Can anybody else tell me besides, where am I going? Him guarding on the improper side, some other things that you saw that was wrong with the video? That was a biggie, right? But I said, I know some therapists that have actually done that. The other thing, definitely, you don't want to teach your patient. You don't want to teach your patient to hold on to their assistive device when they're sitting. You don't want to do that. So you're going to instruct your patients. We're going to go through sit-to-stand transfers in the next slide, but just quickly, you want to teach them, get to the back of the chair, right? You can feel it behind your legs, and then what do?
Reach back.
Reach back. I would prefer that one hand maybe stayed there. Don't have them grab here, okay? And then, as they came down. I prefer to do both, all right? Because this is the most stable. That's the most stable. Wheels should be locked. Brakes should be locked. All right? What else did you see? I mean, he did a nice job guarding, right? He was to the side and slightly behind. He used the gait belt. He used the correct hand for the gait belt. Yep. He had the assistive device there and ready for the patient. That was good. Any other questions with that video? Thanks, Luke. All right. Falling. So, I know. Thankfully, knock on wood, this has never happened to me. But it can happen. It can happen to any one of you. You walk in your patient, and then all of a sudden they become, diaphoretic. They're pale. They're sweating. And then their balance goes. Right. You need to determine pretty instantaneously if it is safe for you and the patient to maintain them in an upright position, or if you need to do a controlled descent to the floor. All right, it is that quick. It really is. All right. So it's never happened to me, thankfully. Like I said, hopefully you have a gait belt on your patient. Karen, do you want to come up here? You guys can practice this when we're going to break. Oh, you're getting class. Karen, look at that. We don't have a gait belt up here. Oh, yeah, we do. Right here. I know that light is great. All right, so quickly, guys, tell me about gait belts. What's the proper fit?
Around the hips.
Two fingers. Yep.
Around the hips.
The thing about being around the hips, though, what if the person pulls it up and then if your waist is smaller, then it's too loose?
Well, you have to determine that. If it's riding all the way up, then you have to obviously make it a little snugger. But when you have a patient and you're meeting them for the first time, explain to them what you're doing, why you're doing it, okay? Because they're going to be like, some patients are going to be like, whoa, wait, no. Tell them it's for safety. All right, so Karen is walking along, dig-a-doon. All right, so my hand is right here. My other hand is free. Hello. My other hand is free to help with whatever I might need to help her with. If you saw in the video, his hand was where?
On the shoulder.
Right, as long as you're not impeding the progression of the walker, you're not holding the patient back, that's okay. All right, so Karen's walking, and all of a sudden she feels like she's going to go down. I decide, well, I'm going to help her. I go down like that. Now,
so your knee's behind.
Yes.
Her butt?
No, in between. I was right here. I was right here.
She wants to try to.
And I could either turn to make it a wider base or whatever, but it's like this.
Yeah.
Okay.
And then do you put your hand behind
If
the
you
head?
can, God bless you, if you can. But hopefully you're preventing their head from either coming in contact with the floor. Like Karen said, you want to, at that point, you're going to grab probably 2 hands on the gait belt.
Yeah, and really you're trying to just lessen the impact.
That's the goal.
And you don't want to get hurt. You don't want to get hurt in the process either. So.
I feel you.
Yeah. So you do the best you can. And Kari was using her leg and her hips, like the biggest parts of her body, right? I mean, she's not a big person, so you just do the best you can.
Hopefully that'll never happen to any of you. But I'm just trying to teach you. And again, it's such a split. It's going to happen instantaneously. But you're looking for those signs and symptoms that, whoa, they're not doing okay, right?
Oh, and the
I have had Oh, yeah. I have had patients who have become started sweating and not, and like Karen just mentioned to me, is in those circumstances where you have somebody whose blood pressure is plummeting all over the place, or they're just getting up to ambulate, this is new or whatever, you might want to ask for somebody to follow with a wheelchair in those circumstances, okay? So then if you'd be like, whoa, help, you know, somebody hopefully would be right behind that can scoop them underneath
It's called a
them.
wheelchair follow.
It's called a wheelchair follow.
And you can always ask for that.
Has anybody ever volunteered and been the wheelchair follower? There you go. So, I used to do that as a student when I was trying to get in. Alright, so precautions or contraindications for using a gait belt. You can't use it in all circumstances. You definitely don't want to use it on a patient who has just had abdominal surgery. Okay? A colostomy bag. You don't want to put it over a colostomy bag. Somebody who has a fractured rib or spine. Probably not. Precautions. Somebody who has a pacemaker. COPD, restricted breathing, any type of cardiac condition, you want to just, it's a precaution. I'm not saying you don't not use it, but take it into consideration and listen to your patients. If you have a patient, you're walking, is that a question?
Yeah.
Okay.
What about like the pumps, like the baclofen pumps?
That's fine.
It's fine.
Those are down by your liver, right?
Yeah.
Yeah, just make sure the gait belt is,
They're usually actually right in the pelvic area, right?
but make sure the gait belt might be a little bit higher than
You're
that.
talking about for
Because they put it
diabetes,
above
those
it,
pumps,
but I
the
wouldn't put it
insulin
over
pumps? Is that
Okay.
what
She
you
said a baclofen pump.
What's that?
It's, go ahead.
Like releases, kind of makes you more like flexible, I guess. Like
Baclofen is a drug that it's an anti-spasticity drug, and you can take it either orally or you can have it administered through a pump. And the pump actually is housed sort of in the pelvis area, and it goes around to the spine, and so it delivers medication to reduce spasticity. And so a lot of times you'll have patients with spinal cord injuries might have it.
CP.
Children with CP, right?
Somebody who has really high tone, somebody who you want to control it all the time. Like when you take medication, you have peaks and valleys. A baclofen pump, usually the medicine, you try to keep it the same. But good point. So you want to make sure that, I mean, if you can't, then let's say you cannot use a gait belt. We're talking about contraindications. What would you do? You'd have to hold, just to the best of your ability, hold the patient. You don't want to be yanking up on their other clothing, all right? Because that's not really going to provide a lot of stability. And again, if you're using a gait belt, make sure it's over their clothing and not on their bare skin. All right. So you might have a patient refuse, you know, or always listen to your patients if they say, oh, that's too tight. You know, it might be, it might not be. Explain to them how tight it should be, and if it is too tight, just loosen it, you know, just a little bit. It's better to have than to not have completely.
And if a patient tells you they don't want to use a gait belt, and you determine that it's safe to still do the transfer, what else should you do? What do you think? Put it on FEDOT.
I'll put it in your notes.
Put it in your notes.
There you go, documentation.
Because you want it in the notes that the patient refused, just in case, right? In case something happens, you want it there that the patient, you asked them to use it, they said no.
And did somebody say grab somebody else?
Yeah.
Yeah, okay. You can grab somebody else too if you feel that, you know, they're not going to be safe. All right, so guarding, we're going to break up in just a few minutes here, and you guys get to practice. We have a bunch of different walkers. We're going to work on a sit-to-stand transfer. So basically, some good points from the video. He made sure the individual, before they stood up, what did they have to do? They had to get to the front of the chair, right? And I know that you've worked on that in lab with Karen. You might have to facilitate that either by, you know, weight shift, come forward. If the patient can independently do it, they can use their hands, push down with their legs, come forward. If they have a hip replacement, what are we watching out for?
90 degrees.
90 degrees. They got this drilled in. 90 degrees, right? You don't want to flex past 90. I don't want to
Cross
Yeah,
midline.
internally rotate. You got it. Okay. So have your patient come to the edge of the chair, right? And another important component of sit to stand is anterior weight shift, right? Because you can't stand up back here. You have nose over toes, right? So you're going to come forward and have them push off from the stable surface. Brakes are locked on the wheelchair, and they're pushing off from the stable surface. Okay. I've seen it a million times. Million and one. I've seen it, all right? Not stable, okay? So you really want to instruct your patients to push off from the chair, all right? So they're standing.
And then one arm at a time to grabbing that or no?
When, to go back down?
No, when you stand up, you stand up.
You
You're holding
can,
it.
I prefer this.
Yeah, and then once you're standing up, then
Oh, one hand then the other, yep.
Okay.
Yep,
We're both at the same time.
whatever, yeah,
Okay.
whatever is the, you know, the easiest for them. Now, we're reversing it, we're gonna sit down, you teach your patient, like the video, make sure that they're standing, no, you're gonna have them sit like this. Standing this direction, right? So you say, wait till you feel the back of the chair behind your legs, and then you make sure your brakes are locked, and then you have them what? Reach back. If they can't reach back for both, I prefer two, but if they can't, definitely one. And then have them slowly lower down to the chair. Okay? Again, do you see where that collapses?
Yeah.
It was in the middle of that walker, and that patient's hand was right on there.